Here is a structured summary of Chapter 4, Impressions and Casts, pages 35 to 38, based on the provided textbook pages. 1. Introduction and Basic Definitions. Impression. A negative likeness or copy in reverse of the surface of an object, an imprint of the teeth and adjacent structures for use in dentistry, GPT-8. Preliminary impression, primary impression, a negative likeness made for diagnosis, treatment planning, or the fabrication of an impression tray, GPT-8. Preliminary cast, primary, diagnostic cast, a cast formed from a preliminary impression using an impression tray, GPT-8. Final impression, secondary, master impression, an impression that represents the surface for use in diagnosis or the fabrication of a prosthesis. Definitive cast, final, master cast, a replica of the tooth surfaces, residual ridge areas, and/or other parts of the dental arch used to fabricate a dental restoration or prosthesis, GPT-8. Stock tray, a metal or plastic prefabricated impression tray available in various sizes and used principally for preliminary impressions, GPT-8. Custom tray, special, individualized tray, an individualized impression tray made from a cast recovered from a preliminary impression, GPT-8. 2. Principles and objectives of impression making. Principles. Tissues must be healthy before making an impression. Proper space must be provided for the selected impression material. Tray and impression material should be dimensionally stable. A guiding mechanism should be provided for correct positioning of the tray. Impressions should be adequately extended to include the entire basal seat area dictated by limiting and supporting structures. Border molding must be performed in harmony with anatomical and physiological limitations. Impressions must be removed without damage to oral structures. The tissue surface of the impression and the intaglio surface of the denture must coincide. Objectives. Retention, stability, support, preservation of residual structures. Aesthetics. 3. Retention and factors affecting retention. Definition. Retention. That quality inherent in the dental prosthesis acting to resist the forces of dislodgement along the path of placement, GPT-8. A. Anatomical factors. Size of denture bearing area. Retention increases with an increase in size. Maxillary denture bearing area, approx 24, text, cm, squared. Mandibular denture bearing area, approx 14, text, cm, squared. Tissue displaceability. Displaceable tissue recoils during function, leading to loss of retention. B. Physiological factors. Saliva quality and quantity. Thin, watery saliva affords the best retention. Excessive, thick, or ropey saliva accumulates between denture and palate, leading to loss of retention. Absence of saliva, xerostomia, compromises retention and causes irritation, soreness. C. Physical factors. 4. Adhesion. Definition. Physical attraction of unlike molecules to one another, e.g., saliva to denture base and saliva to oral mucosa. Depends on close adaptation of denture, size of denture bearing area, and saliva availability. 5. Cohesion. Definition. Physical attraction of like molecules to one another occurs within the thin film of saliva. High viscosity mucous saliva increases cohesion but can physically displace the denture. 6. Interfacial surface tension. Definition. Tension or resistance to separation possessed by a thin film of liquid between two well-adapted parallel surfaces. Heat-cured acrylic resins demonstrate better surface wetting than autopolymerized resins. Plays a significant role in maxillar retention, but minimal in mandible as mandibular denture borders are immersed in saliva. Stephen's formula for interfacial surface tension. Where F equals surface tension force, K equals liquid viscosity, R equals radius of contacting surfaces, V equals velocity of force, and H equals space between surfaces. Key takeaways: smaller space, H, between tissue and denture, right arrow higher surface tension and retention. Larger surface area, R, covered, right arrow higher surface tension and retention. 4. Capillarity. Definition. Quality or state which causes elevation or depression of the surface of a liquid in contact with a solid. Causes thin salivary film to rise and maximize contact with both denture base and mucosa. 5. Atmospheric pressure. When force is applied perpendicular, away from the basal seat of a properly sealed denture, pressure drops below ambient pressure, creating suction. Peripheral seal. Contact of denture border with underlying, adjacent tissues preventing passage of air. Proper border molding is required to maintain this seal. 6. Gravity. Aids retention of mandibular dentures, especially with added weight. Acts as a dislodging force for maxillary dentures. D. Mechanical factors, undercuts, moderate undercuts, enhance retention due to mucosal resiliency, e.g., unilateral tuberosity, maxillary premolar area, distolingual, lingual to midline of mandible. Severe endocetes, compromise retention, requires surgical reduction or altered path of insertion. Here is a structured summary of Chapter 4, Impressions and Casts, pages 39 to 42, based on the provided textbook pages. 1. Additional retentive and auxiliary factors, page 39, denture adhesives. Commercially available products that enhance retention by increasing adhesive and cohesive properties and by eliminating voids between the denture base and basal seat tissues. B. Suction chambers and discs. Used historically to create negative pressure in the palatal surface of maxillary dentures. Clinical note: best avoided due to their potential to induce inflammatory papillary hyperplasia. C. Muscular factors. Oral and facial musculature and tongue provide supplementary retentive forces. Requirements: artificial teeth must be positioned in the neutral zone between the tongue and cheeks. Polished surfaces of dentures must be properly contoured. Denture bases must be extended to cover maximum area. Occlusal plane must be at the correct level. 2. Objectives of impression making, continued, A. Stability. Definition: the quality of a removable dental prosthesis to be firm, steady, or constant, to resist displacement by functional horizontal or rotational stresses, GPT-8. Factors affecting stability: vertical height of residual ridge, decreases with loss of ridge height. Quality of soft tissue: flabby ridges yield poor stability. Adaptation of denture: closed tissue adaptation ensures proper stability. Occlusal plane must be oriented parallel to ridges and divide intra-arch space equally. Inclined planes promote sliding and instability. Teeth arrangement: arranging teeth in balanced occlusion and in the neutral zone promotes stability. Contour of polished surface must work in harmony with oral musculature. B. Support. Definition: resistance to vertical forces of mastication, occlusal forces, and other forces applied in a direction towards the basal seat tissues. Snowshoe effect: maximum coverage of the denture bearing area distributes forces over a broad foundation, minimizing load per unit area. C. Preservation of residual structures. Critical for long-term prosthetic success. Achieved using a selective pressure impression technique that directs forces onto stress-bearing areas while sparing non-stress-bearing, relief areas. D. Aesthetics. Border and flange thickness depend on residual ridge loss. Proper border molding ensures natural facial lip, cheek support and aesthetic flange contours. 3. Classification of impressions. A. Based on purpose. Diagnostic impression, used for diagnosis, treatment planning, and diagnostic casts, typically made with irreversible hydrocolloids. Primary, preliminary impression, made to fabricate a custom, special tray, made with alginate, impression compound, putty, or heavy body elastomeric materials. Final, secondary, master impression, made to construct the definitive master cast on which the final prosthesis is fabricated, made with Zoe paste, impression plaster, or light, medium body elastomers. B. Based on theories of impression making. Impression theory. Key concepts and technique. Advantages, disadvantages. Mucostatic, passive, non-pressure, minimal pressure. Proposed by Henry Page. Records mucosa in resting state using an oversized tray with spacer. Material of choice, impression plaster. No border molding performed, flanges shorter. Advantage, good stability, minimal tissue distortion. Disadvantage, deprives denture of maximum physiologic coverage. Poor peripheral seal leads to reduced retention. Mucocompressive, pressure technique. Records tissues in a compressed state using heavy viscosity materials, impression compound, Zoe, putty, or closed mouth functional methods. Advantage, good initial retention. Disadvantages, causes overextended impressions, constant pressure leads to increased residual ridge resorption, and tissue rebound causes dislodgement at rest. Selective pressure. Combines principles of pressure and non-pressure techniques. Pressure applied to stress-bearing areas. Relief provided to non-stress-bearing, relief areas via custom tray design. Advantage. Maximizes coverage within physiologic limits while protecting delicate oral structures. C. Based on impression technique. Open mouth technique. Records tissues in a static state with displacement. The operator applies controlled pressure on the tray with the mouth open. Closed mouth technique. Tissues recorded under functional occlusal load. The patient executes functional movements, swallowing, grinning, pursing lips, with occlusal rims traced together. Disadvantages. difficult to control pressure, risk of distorted impressions, and requires even occlusion. 4. Rigid, inelastic impression materials, page 42, A impression plaster, type 1 dental plaster, composition, features, contains added potato starch to make it soluble and easier to remove from the cast. Use, mainly used as a wash impression in a custom tray. Pros, minimal tissue distortion, good flow, easy manipulation. Cons, pores must be sealed before pouring, brittle, washed out by mandibular saliva, cannot be used in undercuts, messy, rarely used today. B. Impression compound. Properties, reversible thermoplastic material, waxes, resins, fillers. Forms, tray compound, sheets, and tracing stick compound, sticks for border molding. Softened in warm water at approx 65 carat, circ, text, C, or over a flame. Pros, low cost, reusable, correctable, easy to bead and box. Cons, rigid, cannot record undercuts, poor surface detail recording due to high viscosity, causes tissue compression. C. Zinc oxide eugenol, ZOE, impression paste. Form, base and catalyst pastes containing ZOE, plasticizers, and fillers. Use, final wash impressions in custom trays. Pros, accurate detail reproduction, high fluidity, minimal tissue compression, dimensionally stable, easy to bead, box. Cons, setting time affected by temperature, humidity, rigid, distorts around undercuts, hydrophobic, untidy. D. Impression waxes. Features, not sufficiently accurate for final primary impressions, used as corrective materials to refine tray borders. Here is a structured summary of Chapter 4, Anatomic and Denture Landmarks, Maxilla, pages 43 to 46, based on the provided textbook pages. 1. Significance of anatomic and denture landmarks. Purpose. A thorough understanding of landmarks relative to the denture foundation is essential for selective placement of forces based on stress-bearing potential. Achieving maximum denture coverage without interfering with tissue health, function. Ensuring long-term success of complete dentures. 2. Overview of mucous membrane. Structure, composed of epithelium, mucosa, and submucosa. Classification of mucosa, masticatory mucosa, keratinized, covers hard palate and crest of residual ridge. Specialized mucosa, covers dorsal surface of tongue. Lining mucosa, non-keratinized, soft, and flexible, covers lips, cheeks, sulcus, soft palate, ventral surface of tongue, and slopes of residual ridges. Submucosa, connective tissue containing blood vessels and nerves forming the bulk of the mucous membrane. Dense, firmly attached submucosa withstands denture pressure well, whereas thin or loosely attached submucosa is easily traumatized or displaceable. 3. Maxillary anatomic landmarks categorization. A. Supporting structures. Hard palate, composed of palatine processes of maxillae and horizontal plates of palatine bones. The horizontal portion lateral to the midline provides the primary support as it undergoes the least resorption. Rugae, raised areas of dense connective tissue on the anterior third of the palate. Provides secondary support and resists anterior displacement of the denture. Should not be distorted during impressions. Residual alveolar ridge, alveolar bone covered by soft tissue remaining after tooth extraction. The crest provides good support initially but is subject to resorption, making it a secondary stress-bearing area. Maxillary tuberosity, bulbous extension of the residual ridge in the molar region. The posterior part rarely resorbs and provides significant support. B. Limiting structures. Labial frenum, mucous membrane fold in the midline running from the residual ridge to the lip. Contains no muscle fibers, accommodated by a labial notch in the denture flange. Labial vestibule, bounded by the labial aspect of the residual ridge and the lips, extending between the labial frenum and buccal frenum. Main muscle of the lip is orbicularis oris. Buccal frenum, single or multiple folds separating labial and buccal vestibules. Affected by orbicularis oris, pulls forward, levator unguli oris, and buccinator, pulls backward, requires more clearance than the labial frenum. Buccal vestibule, extends from buccal frenum to hamular notch. Size varies with buccinator contraction, mandibular position, and bone loss. Distal flange width, height must accommodate the coronoid process during lateral mandibular movements. Hamular notch, pterygomaxillary notch, a depression between the maxillary tuberosity and the pterygoid hamulus. Represents the distal limit of the maxillary denture. Contains thick, compressible submucosa utilized to establish a posterior palatal seal. Fovea palatini, two ductal openings of palatal mucous glands located on either side of the midline in the hard palate. Serve as a reference landmark for posterior extension. Denture usually extends 1, text 2, text mm, beyond fovea. Vibrating line, imaginary line across the posterior palate marking the division between movable and immovable tissues of the soft palate, GPT-8. Anterior vibrating line, imaginary Cupid's bow-shaped line at the junction of attached tissue over the hard palate and movable tissue of the soft palate. Located using the Valsalva maneuver, blowing through pinched nostrils. Posterior palatal seal, PPS, area. The soft tissue area at or along the junction of the hard and soft palates on which pressure within physiologic limits can be applied by a complete denture to aid in retention. Located between the anterior and posterior vibrating lines. C. Stress-bearing areas. Primary stress-bearing area, horizontal slopes of the hard palate lateral to the median suture. Secondary stress-bearing areas, crest of the residual alveolar ridge. Palatal rugae. Maxillary tuberosity. D. Relief areas. Areas requiring relief on the intaglio surface of the denture base to avoid pain, necrosis, or instability. Mid-palatine suture, median palatal raphe, thin mucosa overlying dense bone, unyielding. Incisive papilla. Protects nosopalatine nerves and blood vessels exiting the incisive foramen. Pressure causes burning sensations or numbness in anterior palate. Torus palatinus, if present, midline bony protuberance. 1. Posterior palatal seal area, continued, page 47, anatomical subdivisions of posterior palatal seal. Posterior vibrating line, imaginary line at the junction of the aponeurosis of the tensor veli palatini muscle and the musculature of the soft palate. Marks the demarcation between the portion with limited movement and the markedly displaced soft palate. Located by asking the patient to say, ah, in a normal, unexaggerated manner. 2 separate confluent areas, postpalatal seal, extends medially from one tuberosity to the other. Pterygomaxillary seal, extends through the hamular notch for 3, text 4, text mm, anterolaterally approximating the mucogingival junction. Functions of posterior palatal seal. Impression tray, establishes positive contact posteriorly, prevents impression wash from sliding into the pharynx, guides tray placement, creates slight tissue displacement, and verifies retention. Complete denture. Primary function is retention, reduces gag reflex, prevents food accumulation under denture, reduces tongue discomfort, compensates for methyl metaacrylate polymerization shrinkage. 2. Methods for recording posterior palatal seal, pages 48 to 50, a scraping of master cast, conventional, empirical method, functional scraping of cast, performed on the master cast using a trial base. Anterior and posterior vibrating lines are transferred from the mouth to the cast using indelible markings. The deepest region, either side of midline, 1/3 the distance anterior to posterior vibrating line, is scraped to a depth of 1, text 1.5, text mm. Midpalatine raphe area scraped to 0.5, text 1, text mm. Tapers toward hamular notches, anterior vibrating line, and posterior vibrating line. Advantages. Increases trial base retention for jaw relation, lets patient experience retentive qualities early, reduces post-extension adjustment time. Disadvantages. Technique sensitive. Excessive scraping causes over post-damming. Arbitrary scraping of master cast, done by the dental technician prior to processing, not recommended. An arbitrary notched line is formed in the imaginary posterior vibrating line extending to the hamular notches. B. Impression techniques, physiological methods, fluid wax technique. Wax designed to flow at mouth temperature is painted within the marked seal area on the final impression. Head position. Frankfurt's horizontal plane is 30 carat, circ below horizontal, soft palate in maximal downward, forward functional position. Patient executes functional soft palate movements. Advantages. Physiological technique, prevents overcompression, avoids mechanical scraping of cast. Low fusing compound technique, green stick compound used in a manner similar to fluid wax. 3. Errors in establishing posterior palatal seal, page 49, underextension, most common cause of seal failure. Causes, using fovea palatini as absolute limit, patient's gag reflex leading to short borders, incorrect line delineation, or arbitrary technician scraping. Overextension, causes mucosal ulceration, painful deglutition, or sharp pain over the hamular process. Under post-damming, air bubbles escape under posterior border when tested wet, corrected by adding wax, resin seal. Over post-damming, results from excessive cast scraping, causes mucosa irritation and denture dislodgement. 4. Mandibular anatomic landmarks categorization, pages 50 to 53, A. Supporting structures. Buccal shelf area, boundaries, medially by crest of ridge, laterally by external oblique ridge, anteriorly by buccal frenum, posteriorly by retromolar pad. Clinical significance, primary stress-bearing area of the mandible. Lies at right angles to vertical occlusal forces and is covered by strong cortical bone. Area width increases with ridge resorption. Residual alveolar ridge slopes. Slopes provide secondary support. Crest is covered by cancellous bone with non-resilient fibrous tissue and is not suited for primary stress bearing. B. Limiting structures. Labial frenum contains a band of fibrous connective tissue attached to orbicularis oris, requires a groove, relief notch. Labial vestibule extends between labial and buccal freni. Length limited by orbicularis oris and incisivus labii and ferraris. Buccal frenum, ovalis depressor unguli oris, requires wide clearance due to active horizontal, vertical movements. Buccal vestibule extends from buccal frenum to retromolar pad. Distobuccal area is influenced by the masseter muscle pushing against the buccinator, produces the masset-Eric notch in the distobuccal flange. Retromolar pad, triangular pad of tissue at the distal end of the ridge. Contains non-keratinized epithelium, loose areolar tissue, glandular tissue, fibers of buccinator, superior constrictor, pterygomandibular raphe, and temporal tendon. Must be covered by the denture base to maintain border seal and prevent bone loss. Lingual frenum, ovalis genioglossus muscle, extremely active and requires a shallow notch. Alveololingual sulcus, space between the tongue and residual ridge extending from lingual frenum posteriorly to retromylohyoid curtain. Anterior region, from lingual frenum to premilohyoid eminence, houses sublingual crescent area. Flange extends down to contact flow of mouth. Middle region, extends from premilohyoid fossa to distal end of mylohyoid ridge. Curves medially due to mylohyoid ridge prominence and action. C. Stress-bearing areas. Primary, buccal shelf area. Secondary, labial and lingual slopes of the residual ridge. D. Relief areas. Crest of residual alveolar ridge, contains underlying cancellous bone. Mylohyoid ridge, prominent ridge covered by thin mucosa, sharp edges cause soreness. Mental foramen, lying on the labial aspect, severe ridge resorption causes pressure on mental nerves, vessels, leading to numbness or burning of the lower lip. Genial tubercles, spiny bony projections on anterior lingual aspect exposed following severe resorption. Torus mandibularis, if present, bony exostosis on lingual aspect of premolar area. Here is a structured summary of Chapter 4, Preliminary Impressions and Primary Casts, pages 58 to 61, based on the provided textbook pages. 1. Mandibular Preliminary Impression Steps and Techniques, pages 58 to 59, A. Impression Compound Technique, continued, seating the tray. Tray is positioned, and the patient is instructed to slightly close the mouth and raise the tongue while vertical pressure is applied on the tray in the molar region. Cheeks are Here is a structured summary of Chapter 4, Impressions and Casts, pages 54 to 57, based on the provided textbook pages. 1. Mandibular Anatomic Landmarks, continued, pages 54 to 55, Distolingual region and retromylohyoid space. Flange slope. The lingual flange in the middle region is sloped towards the tongue and extends below the level of the mylohyoid ridge so that the tongue rests on the flange to stabilize the denture. Space is provided for raising the flow of the mouth during function without displacing the denture. The seal is maintained during functional movements. Flat ridge modification. If the ridge is flat, the denture border in this area may be made thicker. 4. Text 5. Text for better stability and support. Distolingual region. The flange passes into the retromylohyoid fossa and turns laterally towards the ramus. It completes the S shape of the lingual flange. Retromylohyoid space, an anatomic area in the alveololingual sulcus located lingual to the retromolar pad. Boundaries. Bounded anteriorly by the mylohyoid ridge, posteriorly by the retromylohyoid curtain, inferiorly by the flow of the alveololingual sulcus, and lingually by the anterior tonsillar pillar when the tongue is relaxed. GPT 8. Mandibular relief areas. Crest of residual alveolar ridge can be sharp, spiny, or knife-edged. requires relief when non-resilient. Mylohyoid ridge, prominent and sharp ridges can easily be traumatized by the denture base and require relief. Mental foramen, lies on the crest of the ridge under severe resorption. Compression leads to lower lip numbness. Genial tubercles, present lingual to the anterior body, becomes prominent with severe resorption. Torus mandibularis, bony prominences bilateral on the lingual aspect of the premolar region. Surgical removal is preferred. Surgical contraindications require relief. 2. Preliminary impressions, pages 55 to 57, main objective and requirements. Objective: to make an accurate preliminary impression to fabricate a custom, special tray. Requirements: obtain an accurate impression of the entire denture-bearing surface of each jaw. Record the full extent of the sulcus. Ensure all anatomic landmarks are recorded. Material and tray selection. Material selection: high viscosity materials compensate for tray deficiencies. Commonly used materials include impression compound, irreversible hydrocolloids, alginate, silicone putty. Tray types: perforated for alginate or non-perforated for impression compound, prefabricated metal, plastic stock trays. Metal is preferred for rigidity. Sizing: selected using dividers, calipers. The tray should be 5 mm larger than the residual ridge to cover tuberosities and retromolar pads. 3. Position of patient and operator, page 56, impression type. Patient position, operator position, chair height, maxillary impression, upright, head and neck aligned with trunk, occiput firm on headrest. Right rear or rear position, mouth level with operator's elbow, mandibular impression, upright, head and neck aligned with trunk, occiput firm on headrest. Right front position, mouth level with operator's shoulder. 4. Sequence and technique for preliminary impressions, page 57. Why make the mandibular impression first? George Alexander Lamb, gagging. Gag-sensitive patients are more likely to gag during maxillary impressions. Making lower first reduces apprehension and increases cooperation. Salivation. Upper impression placement stimulates reflex salivation. Excess saliva pools in the flow of the mouth if upper is taken first. Debris. Detached impression particles from upper impressions can land on lower ridges during rinsing, compromising the lower impression. Technique with impression compound. Patient rinses with an astringent mouthwash to reduce salivary viscosity. Compound softened in hot water, 60 carat, circ, text, C, kneaded uniformly, formed into a roll, 1.5, text, cm, diameter, and loaded onto a non-perforated tray. A trough is indented with a finger to receive the crest of the alveolar ridge, deeper posteriorly, shallower anteriorly. Resoftened, tempered in hot water, inserted from the left side at right angles, rotated clockwise engaging the right corner, centered, and seated from midline distally. Here is a structured summary of Chapter 4, Preliminary Impressions and Primary Casts, pages 58 to 61, based on the provided textbook pages. 1. Mandibular Preliminary Impression Steps and Techniques, pages 58 to 59. A. Impression compound technique, continued, seating the tray. Tray is positioned, and the patient is instructed to slightly close the mouth and raise the tongue while vertical pressure is applied on the tray in the molar region. Cheeks are stretched to prevent them from becoming trapped under the tray. Border molding and functional movements. Labial and buccal flanges are border molded. Patient is asked to move the tongue from side to side and then protrude it slightly. Setting and removal. Material takes longer to set intraorally than outside due to poor thermal conductivity. Sufficient time must be allowed to prevent distortion. To remove, the patient slightly closes the mouth, cheeks are retracted to break the air seal, and the tray handle is lifted upward and backward using the thumb and fingers. Evaluation and refinement. Evaluated for extension, anatomical landmark reproduction, tray exposure, wrinkles, or voids. Deficient borders can be added using low fusing compound, softened in warm water, and reseated. Must be poured within 1 hour to minimize warpage from internal stress release. B. Irreversible hydrocolloid, alginate, technique. Tray preparation. Requires support from a perforated stock tray due to poor tear resistance. Tray boundaries can be extended using modeling wax or boxing wax, e.g., 2, text, 3, text, clearance. Loading and placement. Mixed to a slightly thicker consistency, loaded onto the tray, and small amounts placed on the retromylohyoid area and labial vestibule to prevent air traps. Removal. Removed in a single quick snap, rinsed, dried, and inspected. Storage. Must be poured immediately due to syneresis, imbibition. C. Silicon putty technique. Base and catalyst mixed in equal quantities and loaded onto a non-perforated tray coated with tray adhesive. Removed in a snap, difficult to refine, but pouring can be delayed compared to hydrocolloids. 2. Maxillary preliminary impression steps and techniques, pages 59 to 61, A impression compound technique. Preparation and loading, softened in hot water, 60 carat, circ, text, C, formed into a ball, and placed over the center of a non-perforated stock tray. Molded outward using both thumbs, holding tray from rear, to form a trough corresponding to the alveolar ridge. Insertion and seating. Operator holds the tray handle pointing toward the patient's right. Left hand index, middle fingers retract upper lip while the tray is rotated into the mouth. Centered using the labial frenum as a guide. Patient slightly closes mouth while upper lip is lifted upward and forward. Seating sequence, seated anteriorly first into the labial sulcus, then posteriorly until compound contacts the ridge. Upward and backward force applied under the tray in the molar regions. Border molding. Lips, cheeks molded. Patient asked to open mouth wide and move mandible side to side to mold the dystopical flange around the coronoid process. Removal and evaluation. Patient partially closes mouth, cheeks retracted to break seal, and tray pulled downward and forward. Evaluated and poured within 1 hour. B. Irreversible hydrocolloid, alginate, technique. Tray extended with wax if necessary, especially at the palatal vault in high palatal vaults. Posterior palatal seal area wiped with gauze to remove excess mucinous saliva. Material loaded into tray, and a small quantity placed directly on the palatal vault and buccal vestibule. During setting, patient keeps eyes open, relaxes, and breathes through the nose with head bent slightly forward to prevent material flow down the throat. Removed in a snap and poured immediately. 3. Preliminary, primary cast, page 61, definition, cast formed from a preliminary impression, used primarily for diagnosis, treatment planning, or fabricating a custom tray. Material, poured using model plaster, dental plaster, regardless of the preliminary impression material used. Here is a structured summary of Chapter 4, Custom Trays, pages 63 to 69, based on the provided textbook pages. 1. Cast dimensions and retrieval, page 63, cast recommended dimensions. Base thickness, 10, text, 15, text, mm. Land area width, 2, text, 3, text, mm, sloped at 45 carat, circ, sulcus depth, 2, text, mm, below the land area. Ridge orientation, parallel to the base of the cast. Retrieval of cast from impression. For impression compound, the cast with tray is immersed in warm slurry water at 65 carat, circ, text, C, for 5 minutes. Once softened, the impression easily separates from the set plaster, stone cast. 2. Custom trays, overview and objectives, page 65, definition, an individualized impression tray made from a cast recovered from a preliminary impression. It is used in making a final impression, GPT-8. Objectives, confine and control the final impression material. Obtain minute details of the denture bearing area. Develop a proper border seal. Ensure uniform distribution of the final impression material. Ensure planned distribution of pressure on residual ridges. Requirements: rigid, dimensionally stable, easily adjusted, easy to construct, smooth with no sharp edges. 3. Types of custom trays and spacer designs, pages 65 to 66, a custom tray with spacer. Indication: ideal, well-formed ridges where uniform pressure can be applied. Extension: extends 2, text, mm, short of the vestibule reflection. Spacer: 2, text, mm, uniform baseplate wax spacer. Maxilla: stops at the anterior vibrating line, does not cover PPS area. Mandible: stops short of the retromolar pad. Tissue stops: 4 square or rectangular wax cutouts, 2, text, mm, in size, placed on non-stress bearing areas, 2 in canine region, 2 in molar region on ridge crest, to orient the tray and maintain uniform impression material space. B. Custom tray with relief, close-fitting tray, indication, ridges requiring targeted pressured structures like incisive papilla, mid-palatine suture, sharp spiny mandibular ridges. Technique: 1 thickness of baseplate wax applied directly over relief areas on the cast. The close-fitting custom tray is adapted over these areas without a full spacer. C. Custom tray with window. Indication: flabby, mobile, or displaceable tissue areas, most commonly anterior maxillary, mandibular ridges. Technique. The area of flabby tissue is outlined and left exposed via a window in the custom tray to record the displaceable tissue with minimal pressure using a wash material. 4. Fabrication steps and outline design, pages 66 to 67, outlining preliminary cast, vestibular extension line, drawn at the point where mucosa turns into the sulcus. Tray extension line, drawn 2 text mm, short of the vestibular line, and elevated, notched by 1 text mm, at frenum attachments. Posterior boundaries, maxilla, line joining hamular notches passing 2 text mm, posterior to fovea palatini. Mandible, line just beyond the retromolar pad. Blockout and separating medium, underkits blocked out with wax. Separating medium, cold mold seal, petrolatum, tin foil, applied to the cast. 5. Materials and techniques for fabrication, pages 68 to 69, autopolymerizing acrylic resin, self-cure, mechanism, benzol peroxide initiator activated by tertiary amine, dimethyl para-toluidine, upon mixing powder and liquid. Pros: rigid, inexpensive, easily trimmed, adjusted. Cons: dimensional changes during first 24 hours, best used after 24 hours, potential tissue sensitizer. Fabrication methods: sprinkle-on method, powder sifted onto cast using a perforated container and saturated with liquid monomer using a dropper. Built up layer by layer to approx 2.5 text mm thickness. Advantage: minimal material waste. Disadvantage: hard to maintain uniform thickness, risk of porosities. Dough method: powder and liquid mixed in a jar. At dough stage, rolled, flattened between 2 glass slabs with 2 text mm spacers using wet cellophane sheets as a separating medium. The 2 text mm resin sheet is adapted onto the lubricated cast with light finger pressure and trimmed. Advantage: faster, uniform thickness, fewer porosities. 6. Fabrication of tray handles, page 69, dimensions and location, must approximate the position of missing teeth to support lips, cheeks without distorting vestibules. Maxillary tray, single midline handle, 8 text mm, height, 8 text mm, width, 4 text mm, thickness, slightly concave antero-posteriorly and mediadistally. Mandibular tray, 3 handles, 1 anterior midline handle, 2 auxiliary molar region handles, for stabilization and orientation during insertion. Attachment, formed from acrylic dough and attached to the riffin tray surface wetted with monomer. Here is a structured summary of Chapter 4, Border Molding and Final Impressions, pages 71 to 76, based on the provided textbook pages. 1. Border molding, peripheral tracing, definition and purpose. Definition: the shaping of the border areas of an impression material by functional or manual manipulation of the soft tissue adjacent to the borders to duplicate the contour and size of the vestibule, GPT-8. Main purpose: to establish an adequate peripheral seal for optimum denture retention. Intraoral check of custom trays prior to border molding. Borders must be 2 text mm short of the sulcus reflection. Adequate clearance must be provided for labial and buccal freni. Posterior maxillary extension must cover hamular notches and extend to the posterior vibrating line. Mandibular tray must cover retromolar pads. If a wax spacer was placed during fabrication, it is kept in place during border molding and removed only afterward. 2. Methods and techniques of border molding. Methods of manipulating peripheral tissues. Active method: the patient actively performs functional movements, e.g., puckering, smiling, swallowing, moving the tongue, to shape the borders. Passive method: the clinician manually manipulates the lips and cheeks, e.g., elevating, pulling outward, downward, inward. Techniques of border molding. A. Incremental or sectional border molding. Sections of the tray periphery are refined individually using low-fusing green stick compound or heavy body elastomers. Recommended for beginners as each section can be refined sequentially. Sequence of green stick compound application. Maxillary border molding sequence and movements: labial flange, passive, elevate lip and pull outward, downward, and inward. Active: patient puckers lips and sucks on the operator's finger. Buccal flange, buccal frenum area, passive, elevate cheek, pull outward, downward, inward, and move backward and forward. Active: patient puckers lips and smiles. Dystopical area, passive, pull cheek outward, downward, and inward. Active: patient opens mouth wide, closes slightly, and moves mandible from side to side, accommodates movement of the coronoid process. Posterior palatal seal area, active. Patient says, ah, in short, vigorous bursts. Mandibular border molding sequence and movements, labial flange, passive, lift lip slightly outward, upward, and inward. Buccal flange, buccal frenum area, passive, lift cheek outward, upward, and inward, move backward and forward. Active, patient puckers lips and smiles. Distobuccal area, masseteric notch area, passive, pull cheek buccally to ensure it is not trapped, then move upward and inward. Active, passive, record masseteric notch by having patient close against downward operator pressure. Anterior lingual flange, active, patient protrudes tongue and pushes it against the anterior part of the hard palate, establishes length and thickness. Middle portion of lingual flange, active, patient protrudes tongue and licks the upper lip from side to side. Distolingual flange, retromylohyoid area, active, patient protrudes tongue, then places it in the distal part of the palate in right and left buccal vestibules. Verification. Extension over the retromolar pad is checked. Patient opens wide. A notch in this area indicates interference from the pterygomandibular raphe. B. Single step or simultaneous border molding. The entire periphery is refined in a single step using polyether, putty, or heavy body elastomeric impression materials. Advantages. Reduced tray insertions, single insertion, prevents stepwise errors from propagating. Disadvantages. Requires tray adhesive, higher material cost, unsuitable for grossly underextended trays. 3. Preparation of the custom tray for final impressions, page 76, before pouring, making the secondary impression, the custom tray is prepared, remove wax spacer, if used, completely scrape out the baseplate wax spacer. Trim tracing material, trim 0.5, text 1, text mm, of green stick compound from the inner, outer, and top surface of the border using a scalpel blade to make space for the wash material. Exception. Do not remove compound over the posterior palatal seal area, as it maintains the seal, prevents excess impression material from escaping into the throat, and guides tray seating. Escape holes. Drill relief, escape holes in the custom tray over non-stress bearing, relief areas, e.g., mid-palatine suture, crest of ridge, to prevent tissue distortion and allow excess material to vent. 4. Final impression material selection guidelines. Clinical condition, tray type. Preferred final impression material. Gross tissue undercuts present. Elastomeric impression materials, polyether, polysulfide, silicone, custom tray with relief, close fitting, zinc oxide eugenol, Zoe, impression paste. Custom tray with spacer. Medium, regular body or monophase elastomeric impression material. Custom tray with window, flabby tissue, impression plaster, for window area, combined with Zoe paste, for rest of tray, or light body elastomer combined with medium body. Here is a structured summary of Chapter 4, Final Impressions, Beading, Boxing, and Definitive Casts, pages 77 to 85, based on the provided textbook pages. 1. Final Impression Techniques, pages 77 to 80, a mandibular final impression. Positioning. Proper tray position is practiced prior to impression making to familiarize the patient. Skin protection. If zinc oxide eugenol, Zoe, paste is used, lips and facial skin are coated with Vaseline, petrolatum. Seating sequence. Material is loaded evenly. Patient lifts tongue slightly while the tray is rotated, centered anteriorly, and seated with downward pressure on auxiliary posterior handles so buccal flanges contact the buccal shelf. Setting. Allowed to set with the patient's tongue resting against, touching the upper lip. B. Maxillary final impression. Seating sequence. Tray is wetted with material, inserted by centering and aligning the labial notch with the labial frenum. Seating force. Upward pressure applied in molar regions until seated posteriorly in hamular notches, then supported at the hard palate anterior to the posterior palatal seal. C. Final impression using custom tray with window, flabby ridges, custom tray setup, window constructed over the displaceable, flabby tissue area. Border molding, completed using green stick low fusing compound. Primary wash, Zoe impression paste is applied to the main tray area. Window injection, impression plaster, or light body elastomer, is painted or injected onto the window area to record flabby tissue in an undistorted, zero pressure state. Alternative method, dual elastomeric impression, medium body elastomer for the main tray combined with light body elastomer for the flabby tissue window. D. Alternative final impression techniques. Using stock trays, used for ideal ridge conditions when time is restricted. Primary impression made with putty elastomer, compound, borders trimmed 0.5, text, mm, and a final wash made with light body elastomer or Zoe paste. Using record bases with occlusal rims, closed mouth technique, indicated for atrophic ridges in edentulous mandibles. Functional closed mouth impression made using tissue conditioning material under occlusal loading, talking, swallowing, smiling, followed by a final wash using light body elastomer. 2. Impression inspection and disinfection, page 80, inspection, check for air inclusions, voids, and accurate landmark reproduction. Small voids may be filled with wax, large voids require remaking the impression. Disinfection, immersed in iodophor or 2% glutaraldehyde for 10 minutes. 3. Definitive, final, cast fabrication, pages 80 to 84, definition, a replica of the tooth surfaces, residual ridge areas, and or other parts of the dental arch used to fabricate a dental restoration or prosthesis, GPT-8. Material, poured using dental stone, vacuum mixed and vibrated. Beading and boxing methods. Purpose, preserves the depth and width of the sulcus, borders and produces the desired base form, thickness without damaging borders. A. Wax boxing method. Suitability, ideal for Zoe impression paste, difficult with elastomers. Beading, A4, text mm, wide strip of beading, baseplate wax is attached 3, text 4, text mm, below the impression border, running parallel and horizontal to the denture border. Lingual tongue space of mandibular impression is enclosed with a wax sheet. Boxing. Boxing wax or baseplate wax strip is wrapped vertically around the beading to form a container extending 10, text 15, text mm, above the highest point of the impression. B. Plaster boxing method. Suitability, suitable for all impression materials. Procedure. A 1:1 mixture of plaster of Paris and pumice is prepared, 15, text mm, thick on a glass slab. Impression is embedded tray side down into the mix until the mix is 5, text mm, below and outside the entire border. Set mix is trimmed perpendicular to the base, leaving a 3, text 4, text mm, ledge surrounding the borders. A 2, text 3, text mm, layer of modeling clay is added over the ledge, and wax boxing strips are wrapped around the perimeter extending 10, text 15, text mm, above the highest point. 4. Indexing the cast, pages 84 to 85, purpose, permits accurate removal and reseating of definitive casts on an articulator to verify jaw relations or check processing error remounts. Indexing methods, groove indexing, V-shaped grooves, 5, text mm, depth, cut into the base using a lathe-mounted wheel. Maxillary cast, 2 perpendicular lines drawn through the center. Mandibular cast, lines marked under the thickest ridge areas. Notch indexing, 3 VC-shaped notches cut into the 3 corners of the cast base, 1 anterior, 2 posterior, using a sharp knife, wheel. Split remounting plates, commercially available 2-plate systems, male, female, locked with a pin. Female component embedded, fused directly into the base of the stone cast prior to mounting. Advantages, highly precise, permits rapid removal and remounting. Disadvantages, expensive, requires extra attachment step. Chapter 4 Summary Key Takeaways. Success or failure of complete dentures depends heavily on accuracy in impression making. Border molding with low fusing green stick compound and final wash impressions using Zoe paste represent the standard selective pressure technique. Proper beading, boxing, and cast indexing ensure accurate definitive casts and precise laboratory remount procedures.